PEEP is basically the pressure present at the end of expiration. Since pressure is directly proportional to volume, any excess volume will also create excess pressure. In a patient who is mechanically ventilated, there are two sources of the PEEP in these patients. So, one kind of PEEP, which is because of the ventilator, designated here in red, is the extrinsic PEEP, and the pressure of the volume of the air, which is present in the lungs at the end of expiration, creates another type of pressure, positive pressure, and that's called as intrinsic PEEP or auto PEEP. So, in a normal patient, at the end of expiration, the alveoli are collapsed and it's ready for the next breath cycle. But in a patient with asthma or COPD, the bronchioles or the bronchi, they are collapsed, and there is an obstruction for the volume or the air to escape from the alveoli. This excess volume creates an excess pressure, resulting in the auto PEEP. If you look at the pressure volume loops, you will see in the flow loop that this excess volume, because of the incomplete exhalation, creates some positive pressure, that's called as auto PEEP. So now, instead of coming to the baseline, there is an already excess pressure from where the next breath cycle starts. So if we go on to give the next breath cycle, that is, a ventilator decides to give the next breath cycle in the patient with the auto PEEP, then it can cause something called as ventilator associated lung injury. So the breath cycle, which is actually designated by minute volume or minute ventilation, which is basically tidal volume into respiratory rate, it causes the lung injury due to excess volume and pressure created over there. So what are the techniques which we can designate to decrease this auto PEEP? So the first one is we can decrease the minute ventilation. That is, we can decrease the respiratory rate, because it's not safe to decrease the tidal volume. We can always decrease the respiratory rate. The other technique is we can increase the expiratory time, so that the excess volume of the air which is left in these alveoli, it gets more time to actually escape these alveoli. And the third one is to open up these collapsed bronchi or bronchiole, we can give more bronchodilators or steroids.